take that as a yes. Okay, so we're going to talk a little bit about what is neuropsychology. We're going to talk about the factors that I consider as a neuropsychologist when I'm doing an evaluation with a child or a young adult that has epilepsy. I'll talk a little bit about general, what we call neurocognitive constructs, so things like attention, memory, and learning, how they fit within the brain and how they can impact epilepsy. We'll talk a little bit about the psychosocial factors that need to be considered when we're thinking about epilepsy, and then again, we'll have some room for questions and discussion. So what is neuropsychology? Neuropsychology is a small discipline that most people have never heard of until they need us. We work primarily in hospital settings, outpatient hospital settings, but we also do work in the community as well. Typically, a neuropsychologist has a PhD or a PsyD in clinical psychology with graduate level coursework and subsequent fellowship training in neuropsychology. So it's essentially within the realm of clinical psychology with some subspecialization, usually a 2-year accredited fellowship in neuropsychology, typically in a hospital setting. We specifically study brain behavior relationships. We are not involved with directly with the EEGs or the MRIs, although we have some contribution with functional magnetic resonance imaging, which looks at things like language functioning in the brain. But by and large, most of our tests that we give are paper pencil measures. I tend to tell families to tell their kiddos there's no shots, no needles, no pokes, nothing like that. Again, mostly paper pencil measures that are standardized. So when I say standardized, what that means is that these measures are compared, so performance on a child is compared to a neurotypical group or a normative sample. So we can look at children ages 9 years, 3 months to 9 years, 9 months of age, and their performance on, say, a language measure or an attention measure, and make some meaningful comparisons. We look at things like global ability. One of those terms that's used is IQ. I'll talk a little bit about that in a second. We look at things like attention, executive function. So executive functions are, you have your intelligence. Now, how do you go about doing things? How do you go about thinking, processing, if trying out something new, and if it doesn't work out for you, how do you alter your plan or your attack or your strategy so you can make things work? Again, we also look at language, understanding, so receptive language and expressive language, naming, word finding, those kinds of things. We assess for memory, both language-based memory, so like, say, for example, a list of words that are read out loud and have the child say them back. We also look at nonverbal or visual spatial memory, which is a little bit harder to assess, but we can talk a little bit about that later. And then we also provide some assessment of academics. Oftentimes, insurance companies do not authorize testing purely for an academic reason. They say, we offer or we cover neuropsychological testing when it's medically necessary as opposed to when it's educationally necessary. So fortunately for kiddos with neurological issues, including epilepsy, we see academic issues, so therefore we can do neuropsych testing, and that is typically covered by insurance companies. We also assess adaptive skills, so that would be, daily functioning. So how is the child doing in terms of, putting shoes on correct feet, or being able to tie shoes, or being able to adjust the temperature on the sink for hot and cold, or to help with chores, those kinds of things. And then lastly, we provide assessment of emotional and behavioral function because, as we'll talk about in a second, emotional issues, mood issues, and anxiety are pretty common in epilepsy. So it's important to assess those and to provide recommendation strategies for that. So in talking about or thinking about the neuropsychological functioning in epilepsy, just as Dr. Phillips said earlier, epilepsy is a spectrum disorder. I also, see it like a snowflake. Every kiddo with epilepsy is going to be a little bit different. Even if you have, 2 temporal lobe epilepsy patients, you're going to see other factors or other variables that can make that child unique and different. in the assessment. So when I consider, so if I have a referral from one of our kind neurologists to look at thinking and learning and processing, whether it's a child who's going to be potentially undergoing epilepsy surgery or a child who has, say, a more benign epilepsy condition, I want to look at the clinical features, the types of seizures, the number of seizures they've had, if they've had episodes of status epilepticus, if they have, or their age of onset. So a child who's had seizures since age 18 months is going to be very different than a child who's had seizures since, 14 years of age. Just as Dr. Phillips was also saying in his ESES talk, if you have a child who has seizures and epilepsy and disrupted learning early on, say right around kindergarten, first and second grade, that can have a larger impact than developing seizures a little bit later on when their ability levels have already been solidified. So if a child's just learning to read and they have epilepsy and maybe a really bad run of seizures, they're likely going to struggle with reading down the road. Not definitively, but more likely to. I also want to look at family history. Is there a family history that would support a genetic or some other variable that could be contributing to the child's epilepsy? What do the EEG findings reveal? As also discussed in a previous lecture, interictal discharges that are common can disrupt learning. They can disrupt learning over time, and they can also disrupt learning in the moment. So if I have a kiddo who's coming in for an evaluation and, their interictal pattern, meaning in between having seizures, is really not very good, then that could impact the test results that I obtain. And so I need to consider that information. And then in terms of diagnostic investigations, things like what does the MRI say, what do the PET studies say, and other types of studies, and then also treatment strategies that have been used. So we'll talk again a little bit about this. Anti-epileptic medications can also impact thinking and learning and processing, even though they're essential or crucial for seizure freedom in the vast majority of patients. This is just to give you an idea of the types of syndromes that we see with kiddos who have epilepsy, just to show you kind of the vast nature of this patient population. And even within, so I've seen kids who have benign epilepsy with central temporal spikes, BECs. I've seen kids who have been totally fine, and I've seen kids who've had major issues. So even again, within context, as opposed to even between contexts, we can see variation in performance and in neurocognitive functioning. In adolescents and adults, we have juvenile absence epilepsy, JME, a bunch of other different types of disorders. And then we have distinctive constellations. So you can have a specific disorder such as like Rasmussen syndrome that secondarily results in seizures, or you can have trauma such as a traumatic brain injury that results in seizures. And so each and every one of these distinctive constellations and epilepsies of infancy, adolescence, and childhood can throw a wrench in the system, so to speak, when we're doing these neuropsychological evaluations. So it's important to have a broad understanding of epilepsy and specific disorders, but also have a good understanding of child development. So when I make recommendations, say in the community or for friends and family, who are seeking a neuropsychological evaluation, I recommend, especially in the context of epilepsy, that person has background training in working with kids with neurological disorders, specifically working with epilepsy, and then also has a really good head on their shoulders as it relates to child development. Because again, a child developing seizures at age 2 is going to look potentially vastly different from a child who develops epilepsy at age 15. As I said earlier, anti-epileptic medications can contribute to changes in thinking and learning and processing. And I get the idea, and I agree wholeheartedly with neurologists. Most important, we want to control seizures, because persistent and uncontrolled seizures can impact brain functioning over time, and we see it fairly regularly. And so there are sometimes anti-epileptic medications that have a side effect impacting thinking, learning, processing, or behavior, or something along those lines. And it's a balance of controlling seizures and preventing further decline and worsening of seizures, and also having to deal with the side effects. So we fully appreciate the impact of anti-epileptic medications on kids functioning day to day, but it's kind of a necessary thing at this point, as it relates to current treatment strategies. So just giving you an example here of some of the anti-epileptic medications that have been used, that are commonly used. Prior to the 1990s, we saw more medications that had a sedating effect, which can impact attention and focus and those kinds of things. Then by the mid-90s, we saw an inclusion of medications that seem to have less of a sedating effect and in fact have more of a what they call an activating effect. So you see kids who are a little bit brighter and a little bit more, essentially with it and a little bit more attentive and have better stamina. And yet it could certainly be as a result of seizure control, but it's also the result of a medication that's improving their activity, so to speak. And so sometimes you can see behavioral issues with those activating medications. The notorious one is Keppra or levetiracetam. In my experience, it's been a fantastic medication for helping kids with epilepsy. But at the same time, I often hear stories of kids having significant behavioral issues and mood issues and irritability and explosiveness and those kinds of things with that medication. So it is not a sedating medication, so you don't see that, not to pick on, say, something like Dilantin, which a lot of times is not used in an outpatient setting anymore, that can really sedate someone, or one of the benzodiazepines can really kind of cause sedation, low processing speed, attention issues, and even direct memory problems. And the trade-off with something like Keppra is you don't see those, but sometimes you see the behavioral impact. This is just a little table showing how common cognitive issues are in various presentations. So if you have repeated generalized tonic-clonic seizures, there's a high likelihood that you're going to have problems with aspects of cognition. There's just a variety of them listed on the left side there. Status epilepticus, also highly associated with cognitive issues, anti-epileptic medications. If there's a brain lesion, if it's on the left side versus the right side, they can have a potential impact. We know typically in the vast majority of right-handed individuals that the left hemisphere is responsible for language functioning. And so if you have a brain lesion on the left side, and then say in an adolescent and they're right-handed, that can impact their naming or some other aspect of language processing. And then, of course, we want to consider age of onset, number of seizures, and what kind of EEG abnormalities may be contributing to their presentation. So in neuropsychology, I mentioned that we do paper pencil testing, looking at attention, language processing, those kinds of things. Our specific role is to establish a baseline and compare performance over time. So we know, especially with kiddos who have uncontrolled epilepsy, that they can potentially lose function over time. Or if they're not losing function over time, as Dr. Phillips was saying, they may have this profile where there's a kind of a slower or arrested development. More commonly, I typically see a slower development, meaning that if a child is struggling at age 4, 5, or 6, but they're still making progress, every year that they struggle puts them further and further behind their peers. Similarly, if they have uncontrolled epilepsy, whether it's impacting their sleep, or again, they have the interictal discharges, if you have a kiddo who spends 1 hour of time on homework or schoolwork activity, and about 15 minutes of that time is actually good brain functioning, and the rest is fatigue or interictal issues or who knows what, if you multiply that by, several hours, several days, several weeks, you can see this disparity that happens over time. So sometimes we don't see kids who lose function necessarily after having epilepsy or while they're dealing with epilepsy, but they can have this failure to progress at the same rate. So what we like to do as part of our evaluation is get a timestamp of, hey, this is what your child is able to do at age 8, and then we can compare their performance at 12, 15, 22, those kinds of things. We also like to assess for functioning difficulties that impact school. I always tell parents that the child's job is school. The child's peer network is school. So everything centers around school. Child self-esteem is often, a factor of school. You get grades. You compare your performance relative to other kids. So we know that kids with epilepsy are at risk for having learning difficulties. So we want to try to identify what those learning difficulties are and maybe where the brain regions that are impacting those areas of functioning, so that we can make recommendations for school and for parents to help with functioning and help with improving on-task behavior, help with accommodations and those kinds of things. You may have heard of the term IEP, or Individualized Education Program. That's through the schools that provides a degree of special education support for children. It can be as benign as maybe extra time for tests, or you can have an IEP that includes a special day classroom or even an alternative academic setting. Again, in neuropsychology, we want to localize and lateralize brain functioning. That's oftentimes when kids are being considered for possible epilepsy surgery, and we want to help the team determine whether there would be a positive or potentially negative impact of doing some other type of intervention for treating the seizures apart from medication. Again, we like to assess emotional and behavioral functioning. I think we all do this in medicine, and I think the benefit of the neuropsychological evaluation is that we can spend several hours working with a child, and we can do a little bit more of a deeper dive of assessing emotional and behavioral functioning. That includes providing teachers rating scales, parent rating scales, patient rating scales, having an interview with the patient, having an interview with the family, and sometimes having an interview with teachers, just to get an idea of how that child's doing in multiple settings. In doing all this evaluation, we make recommendations for home, school, and community. And then I put at the end here, we often see kids who are intractable or have uncontrolled epilepsy, and they're being considered for possible epilepsy surgery. And so we do this evaluation to determine if there are risks or, again, potential benefits of on cognition in doing an epilepsy surgery. So all this to say, we want to take into consideration this multifactorial model. Are the deficits, so if we're seeing a child and they're struggling in school, they're struggling at home or on formal testing, is it because they have abnormal epileptiform discharges? Is there a particular condition? Do they have a lesion identified like a sclerosis in the temporal lobe, or if they have like if they had an open head injury, those kinds of things. Medication, as I said earlier, can impact functioning. Is there a secondary process? So meaning that sometimes we'll occasionally see a kiddo who unfortunately has had an oncology issue. So they have a type of cancer, and that cancer can have can either treatment or just by having a tumor or something along those lines can impact thinking, learning, processing, can cause epilepsy. That epilepsy can have a compounding effect on thinking, learning, processing. So what's going on with the kiddo's functioning? And again, what were they doing before their seizures developed? And then we also want to take into strong consideration psychosocial factors. If a kiddo is well controlled with their epilepsy medication and they're, say, a teenager, and they're not taking their medication all that often, and their sleep hygiene is horrible, as it is for many teenagers, that can show up as low test performance. And so we want to address those issues to, again, help the child be maximally impactful at home and in school and community. In terms of a test battery, so we look at things like, again, intelligence. I mentioned this earlier, the construct of IQ. IQ is a theoretical construct. It's intelligence quotient. And the idea was there's a bunch of researchers who got together and said, there are certain variables that when combined, they seem to be a decent predictor of academic and day-to-day and future vocational functioning. And so they came up with the term IQ. I don't hold a lot of water in, as someone who gives IQ tests pretty regularly. I don't hold a lot of water in the construct of IQ by itself, because essentially the test that we use for intelligence testing looks at a variety of different areas of functioning. We look at verbal reasoning, we look at processing speed, we look at working memory, we look at visual spatial skills, and even within those constructs, we look more fine-grained at specific ability to reason using language versus vocabulary knowledge versus what we call general fund of information, so what someone might have learned in school. And so you can see there's a lot of variability that needs to be considered, and all those subtest performances go together to convey this construct of IQ. And the reality is that even outside of epilepsy, we see variability in test performance. So again, I don't like to use IQ just for a number. What I like to use the intelligence measures for is to give me a 30,000-foot view of a child's functioning, and then a little bit of a sampling of their verbal skills, their visual spatial, their working memory, their processing speed, et cetera. And then I can go ahead and do additional testing to test some hypotheses or to address some areas that seem a little suspect. For example, attention. So we have measures that are designed to assess attention in a variety of different ways. It can be sustained attention. So one example is a computer program. What you have is you have letters flashing on the screen like A, P, L, Z, and the child's supposed to hit the space bar every time they see a letter flash on the screen, but when they see the letter X, they don't push anything. So it's like A, L, P, X, R, X, oops, that kind of thing. And it goes on for a long period of time. And so what I can do is I can look at their sustained attention. I can look at maybe their fatigue, how that could impact things, their reaction time. I can look at their impulse control. So if they hit X all the time, but they're attentive otherwise, or they don't hit X and they're very inattentive throughout the test, that gives us some information. As I mentioned earlier, executive functions. Executive functions are, it's a nice buzzword, and I do think it's a meaningful term, but it encapsulates so many things. It's everything necessary for thinking, learning, and processing. So again, it's decision-making. It's start, stop, think, don't think. Reactivity. So if you try something and it's not working, how do you switch your strategy around? So executive functions, we can assess those in a clinic setting. It's sometimes hard to pinpoint what the issue is for a particular child, but I think at the end of the day, we provide a lot of recommendations based on our entire evaluation that can help a child, quote unquote, executive functioning, throughout their day-to-day. We also, again, look at language, so receptive language, expressive language, naming. Sometimes naming is impacted with, say, for example, temporal lobe on the left, usually. They call it dominant temporal lobe, so dominant would be where language is coming from. Left temporal lobe, left frontal lobe can cause word finding difficulties, so it's the tip of the tongue phenomenon, times 20, much worse typically. And so, again, we assess for language functioning. We look at memory functioning, verbal memory. So as I said earlier, say a list of words, the child says that list of words back. And then we assess them over time, say, hey, we're going to do that list of words again. They say the words back again, and we do it a bunch of times. And then we move on to something else. And then 30 minutes later, we say, hey, bud, do you remember the list of words that we read earlier? So that, again, is the ability to assess immediate verbal memory, learning over time, and then what we call remote memory or remote verbal functions. We also look at visual spatial skills. Visual spatial skills, for example, would be putting block design patterns together, seeing like a puzzle that's already been put together and finding like the pieces that go together to make that puzzle. We'll also assess for motor functions, left and right hand. Sometimes the seizures are, near the motor strip or even just in one hemisphere versus another, and the spread of the seizure can actually affect motor functions or some of the sensory functions, and you can sometimes pick that up, the discrepancy on fine motor tasks. We also, again, look at academic achievement, reading, math, comprehension, not so much writing. I think writing is difficult to formally assess because there's so much that goes into writing. So I do have, very frustrated parents who say, hey, writing is a problem for my child. And I would say for most of the kids that I see in the clinic setting, writing is a problem. Why is it a problem? It's because it's an integration of every cognitive process. You have to use your intelligence. You have to use your attention. You have to have good language skills. You have to have decent handwriting. You have to have good ability to, understand your audience, which goes to that executive functions. Like, okay, I need a topic sentence and then supporting document or supporting items and then a conclusion that ties it all together. So yeah, writing is very difficult. It's just hard to assess in the clinic. But I find that when I assess areas of attention and language and memory, I can usually get at what the kind of the more significant variable is that's contributing to writing struggles. And then again, as I mentioned, assess psychosocial functioning, parent rating scales, teacher rating scales, those kinds of things. So in terms of intelligence, as I said earlier, and as has mentioned in the past here, usually we don't see a deterioration in functioning. It's usually a failure to acquire skills at the same rate as peers. And if you think of early development, the brain is continuing to develop from conception all the way on to age 22 or so, and the brain is continuing to myelinate or build connections. And so if you have a disruption at any point in time, you can potentially not get that time back, so to speak. So the term that we use is sensitive periods of development, meaning there's a sensitive period when you are best able to, as a child, learn how to read. So by the ages of 4 would be kind of early. By ages of 5 through preteen, those are the ideal times to learn to read. And if you have not been exposed to reading prior to then, or you have a pattern that looks like a developmental reading disability that no one ever helped you with, by the time you're 12 or 13, it's going to be really hard to read. And so again, we have the potential for a disruption of functioning over time. And I would say a smaller subset of kids that I see have actual declines over time, actually. So you see a pattern where they're making progress, and then things get really dicey with their epilepsy and they start losing function over time. And it's typically those kids that I'm seeing, personally, that they're, epilepsy surgery candidates or have a disorder that's commonly associated with loss of function. So for example, like Rasmussen's encephalitis would be an example of that. So in terms of overall ability, we see that roughly 10% of children with epilepsy have intellectual disability. We see that 50% of children with intellectual disability and what we call cerebral palsy, so like an early injury prenatally, can have intellectual disability. We see intellectual disability more common in West syndrome or disorders that include infantile spasms. And then Lennox-Gastaut, we also see a high number of kids with intellectual disability. So again, the take-home message is a small subset of kids with epilepsy will have intellectual disability, but we often see commonly associated specific neurocognitive issues in kids who have epilepsy. I always tell parents that the attention system within the brain is the most sensitive system. And whether it's epilepsy, whether it's a kiddo who's undergone, chemotherapy or brain radiation, or a child who's had a traumatic brain injury, the attention system is often impacted. So sometimes you'll hear, frontal lobes being, the attention system. Well, as a matter of fact, the vast majority of the brain is actually responsible for modulating and navigating attention. So we see that 1/3 of children with epilepsy tend to have attention problems. ADHD is the disorder, attention deficit hyperactivity disorder. There are essentially 2 types. Dr. Phillips mentioned this earlier. Attention deficit hyperactivity is the hyperactive, actually more often impulsive. We don't see a ton of hyperactive kids. We see mostly impulsive kids who have ADHD. And then the other is attention deficit hyperactivity disorder of the predominantly inattentive type. So that kiddo who's what they call like slow cognitive tempo, the one who's kind of staring off or daydreaming more. So we typically see a little bit more of that in epilepsy. We see that 82% of kids have ADHD symptoms prior to their first overt clinical seizure. We can see epilepsy causes functional impairments in the brain, and again, as I mentioned earlier, impacting, you can have a lesion or an epilepsy in the frontal lobe and the occipital lobe and the parietal lobe on the left and the right, deep focus, surface. It can contribute to ADHD symptoms. We also know that anti-epileptic medications can contribute to problems with attention, concentration, vigilance, is the ability to kind of maintain attention for a long period of time, and processing speed, how quickly you can process information. But as I said earlier, some of those newer medications, anti-epileptic medications that have more of an activating effect tend to impact attention and concentration and processing speed less. So you do tend to see ADHD more commonly in frontal lobe epilepsy and childhood absence epilepsy. So you can have childhood absence epilepsy and have ADHD or ADHD of the inattentive type. Okay. In terms of memory functions, typically we see memory issues with kids who have mesial kind of in the middle portion of the temporal lobe and extending even deeper. So you have your brain, see here, eyeballs here. These are your temporal lobes on the left and right side. So tucked into the temporal lobes, you have some subcortical structure, including the hippocampus, which is responsible for the initial consolidation of memory. Memory itself, so if you have a memory of, like, say, what your address was when you were little, that is not housed in the temporal lobe. That's kind of distributed throughout the brain. So if you, or like, say, for example, your multiplication facts. So if you're in 3rd grade and you're learning, your basic single-digit multiplication facts, that's all going through the temporal lobe and the hippocampus, and it's helping you to consolidate. It's helping you while you're sleeping to encode that information. But several grades later, the temporal lobe is no longer involved in your ability to say what 8 times 4 is. Again, that's distributed throughout the rest of your brain. So more often than not, I will see memory issues in my kids with temporal lobe epilepsies, usually more on the left, because on the left side you see more language-based temporal lobe functioning than on the right. And so sometimes I'll see that, but in my other kids, I'll have lots of parents who have concerns for epilepsy or for memory issues in epilepsy. And usually what I find is there's something else that's going on that makes it look like a memory problem. So for example, if, a child's told, like, hey, when you're done with school today, I want you to grab your backpack and meet me over here. And they're like looking out the window, or they're not paying attention because something else is going on, or they're really tired, or there's something, that's contributing to things. Later in the day, if they don't show up, yeah, it looks like a memory problem, but it could also be something else, like their executive system was off or their attention was off. So all this to say, not all my kids who have epilepsy have memory problems. Many of the kids who come to the clinic who do not have like this circumscribed mesial temporal lobe epilepsy have what look like memory issues, but oftentimes it's something else that's contributing to what looks like a memory issue. And if we make some recommendations to help with that, as in, like, don't give more than 2-step commands at a time because they're not going to remember 3 steps, then that can help with some of the perceived memory issues. Again, in terms of language functioning, we see so the vast majority of people who are right-handed have language on their left side. If you have seizures that come on very early on, so if you have a right-handed individual who has seizures that come on early on the left side, there is a chance that their language could be, and actually even individuals who've never had a neurological injury can have what they call bihemispheric representation of language. You can have language in both hemispheres, or sometimes you can have language on the other hemisphere. The idea being that from a developmental or evolutionary standpoint, the brain values language the most, and so that's the one that's going to get the real estate. So if those regions in the brain that are responsible for language are not working because of seizures, they might push something else out on the other side of the brain so that language actually works pretty well still, if that makes any sense. And if you have any questions about what that can what that can look like. I'm happy to talk about that when we're all done here, if there's still time. Visual, spatial, and perceptual difficulties can be seen in epilepsy. I don't see it all that often because if you look at the left hemisphere and the right hemisphere of the brain, again, thinking traditionally the visual spatial skills are more kind of in the right hemisphere, there's a larger volume of white matter and in theory more connections on that right hemisphere of the brain. So if you have a seizure or a lesion on the right side of the brain, usually the rest of that hemisphere can kind of take over, so to speak. So you typically don't see specific visual spatial deficits in kids with epilepsy, unless it's, you know, some unique system or unique type of epilepsy. So the other good thing is if we have a kiddo who's struggling with some visual spatial skills, you don't typically see that impacting classroom functioning so much. If you do, it might be, say, with writing or doing math. And so there's easy remedies for that. You can work on typing to help with, you know, spacing when in writing, or you can use graph paper for doing math facts and keeping things more organized. So there's ways to kind of overcome those. As I mentioned earlier, executive functions. Executive functions are commonly seen with the frontal lobe, but executive functions like attention is really throughout the entire brain. There's even a lot of evidence to suggest that the cerebellum, which is the little brain kind of way in the back behind the or underneath the occipital lobe that's responsible for fine motor coordination, actually is also implicated in attention and executive functions, like start-stop kind of thing. That's an executive system, and that's oftentimes impacted controlled to a degree by the cerebellum. So yes, when we see dorsolateral, so on the top of the frontal lobes, or orbital frontal, which would be like just above the eyes, you can see specific types of executive deficits, like poor like planning or poor impulsivity, those kinds of things. But again, executive functions are pretty much everywhere and are commonly seen in kids with epilepsy, executive function deficits, I should say. In terms of learning disabilities, we see a large number of kids, 20 to 55% of children with epilepsy have at least one learning disability. We see reading disorder, dyslexia is a common one. Math disorders are common. One could argue that's visual spatial, but math is actually is a bunch of processes. And then 37% have a quote unquote disorder of written expression. So kids who struggle with writing. 50% have school-related difficulties. 50% of kids with epilepsy have school-related difficulties, so half of kids. And then about a third need additional academic support. But less than 1% need to go to a special school. Most of the time, these kids can be managed with, you know, support and advocacy from parents and treating professionals in the public school system with either in a general education classroom or with a 504 accommodation plan, which is an informal, or it's a formal plan that's executed in the general classroom. So like preferential seating, extra set of textbooks that would all be under a 504 accommodation plan, or an IEP, as I mentioned earlier, individualized education program. So moving ahead, I got 10 minutes here. Okay, so common mental health afflictions with epilepsy. So I'm going to use the term disorder here. So mood disorder, depressive disorder, anxiety disorder. And I think the term disorder has this kind of a negative connotation, and I understand why. The way we in mental health and medicine in general look at the concept of disorder as it relates to mental health functioning is, so if you have some depression, depression could be lack of interest in things, irritability, difficulty with sleeping, sadness, tearfulness, all those kinds of things. Then you have features of depression. When it becomes a disorder, it's because those symptoms that I just listed or other symptoms kind of group together and impact your day-to-day academic community functioning. So that's the idea behind a disorder. What it is to say, hey, this is an issue. So if I say, you know, Sally has generalized anxiety disorder, what that means is that when Sally goes to school, when Sally does testing, when Sally goes in for a VTM, you know, when Sally's being considered for possible epilepsy surgery, that Sally is particularly vulnerable to anxiety. And it is a major thing that's going to impact your functioning. So when we make medical or academic recommendations, we need to take into consideration Sally's anxiety because it's a central theme in her overall functioning and development. So again, with regard to mood disorders, we see 12 to 26% of children with epilepsy have comorbid mood disorders. And I know some of these, like, for example, kids with depression, who have intractable epilepsy. My slide here says 20 to 60% of kids have intractable epilepsy, and that's a large, number difference. And where we come up with this in academics is there's a bunch of studies that have been published. And so when you do a distillation of those studies, you see a sample that has kids of 20% and a sample of kids who have 60% likelihood. So you do see some variability, but all this to say is we're highlighting that mood disorders are pretty common in kids with medical issues, or with epilepsy. But I will say that the rate of depression is similar to other kids who have chronic medical conditions. So it's not necessarily that mood disorders or depression in particular is unique to epilepsy. It's unique to, or it's common in chronic medical conditions, of which epilepsy is one of them. And so not surprisingly, you see a smaller subset of kids who have epilepsy, who have well-controlled seizures, have depression, and a larger group of kids with intractable epilepsy, so uncontrolled seizures, equates to more of a chronic nature to the medical condition, more daily impact, and then also, of course, brain functioning can be impacted as well, which can result in increased instances of depression. It's a sad fact, and I don't like mentioning it, but I think it's important to have awareness, is that suicide rate is 10 times higher in kids with epilepsy than in the general population. We typically see kids with the temporal lobe epilepsy having more instances of suicide or suicide attempts. Part of that can be there's within the hippocampus that I mentioned earlier, this kind of the subcortical structures. There's the amygdala. I think Dr. Phelps mentioned that, which is responsible for a lot of emotional control. And so that when that's impacted by seizures, you have a greater instance of more of an externalizing depression, so more of a person who's depressed and actually might do something about that depression or take it into their own hands. And then just a couple other stats here. The children with epilepsy, depression is more common in the older age groups and anxiety in the younger groups. And females and adolescents with epilepsy have significantly higher rates of depression. So a non-clinical depression would be, like they call it, depressive somatoform symptoms. So it's like, or interictal dysphoric disorder. So dysphoria is just like kind of low-level day-to-day depression. And so you can see, excuse me, issues with depressed mood, low energy. Kids with epilepsy have more pain issues, that can be what we call somatic. So they have this heightened sense of pain. Kids with depression in general, adults with depression have a heightened sense of pain. Then you can also have insomnia, and as we know, sleep can negatively impact all sorts of functioning. And then you can have, so depressive symptoms are, deactivating symptoms, and then you can have affective symptoms, which are more like irritability, up and down mood. You can have fear, and you can have anxiety. I will say the take-home message for this slide is that anhedonia is the lack of interest in previously enjoyable activities. You can use that as a measuring tool to assess how someone's doing from a depression standpoint. So yeah, you can look at tearfulness, and in reality, a lot of kids don't have tearfulness. They're a little bit more irritable than they are tearful. But that lack of interest in things that are otherwise enjoyable, that is pretty ubiquitous among kids and adults and people who have depression that is, of a overt neurological, like an epilepsy, or something that's more of a reactionary kind of thing. Lastly, bipolar disorder is seen more commonly in our epilepsy patients, and it typically is more seen in temporal lobe epilepsy. Anxiety disorders are the most common affliction or mental health issue in children. 15 to 25% of patients with epilepsy have anxiety disorder. We also need to keep in mind that fear, or like a panic attack, can also be a simple partial seizure, or could be somehow related to the epilepsy. So a child may not have anxiety and be just fine, but all of a sudden they have this weird, intense fear that overcomes them, that precipitates a seizure event, or actually, is reflective of a simple partial seizure. We sometimes see OCD in kids who have epilepsy. It's usually more of the kiddos who have the temporal lobe or the cingulate, which is also kind of a deep structure in the brain around the temporal lobes. And then we see that 12% of kids with intractable epilepsy also have generalized anxiety disorder. Psychotic disorders. So a psychotic disorder is a disorder of thinking, whether it's a disorganized thought, a hallucination, a thought that, a paranoid thought or persecutory thought. You can see them sometimes only during seizures, only after seizures, or you can see them just randomly. 7 to 9% of patients in the community will have these kinds of things, whereas people who are inpatient tend to have. So like if you have someone who is inpatient from a mental health standpoint, they're more likely to have a psychotic disorder if they have epilepsy. So you do see in 7 to 9% of patients with epilepsy have some degree of psychosis. It doesn't necessarily mean they have like schizophrenia or something like that, but we want to kind of keep that in mind as something to consider. And we also know that you have an increased risk for, psychotic type things as you get into adolescence and as hormones change. So if you see a kiddo who's having, some difficulty and they're 7, 8, 9, 10, that seems like they're having dysregulated thoughts, or they're having something that seems a little bit off, or hallucination, you want to pay close attention to that, because there's a chance that can ramp up in adolescence. And I don't think I need to address the last couple things here. Yeah, no. Okay, so in terms of treatment for mental health issues, psychotherapy is important. Cognitive and behavioral therapy is a common therapy that's used. I'm sure you've heard the term CBT before. What that means is cognitive, meaning it's addressing thoughts and ideas that you have that might be not consistent with what reality is, or thoughts and ideas that you have that can be shifted or kind of worked on so that you can take a different perspective on what's going on in life, or whatever it may be. And then behavioral therapy is, you might have certain behaviors that kind of kindle your anxiety, or that cause you to be more depressed or whatever. And so the CBT therapy focuses on those areas of how you think and then the behaviors you make in order to help you with some changes that can move you in a positive direction. If you work with someone who, on CBT, it's strongly urged that you work with someone who is definitely familiar with epilepsy, and definitely familiar with chronic medical issues. I say this because you can potentially have cognitive and behavioral issues that are because of the epilepsy, because of abnormal brain discharges that are causing you to think X, Y, or Z. And so it's important to have the therapist be aware of, what things can change and what things we have to work around. And it's kind of an evolving process. All this to say, kids with epilepsy are sometimes a challenge to work with, because you really have to pay attention to the nuances. So having familiarity with the medical issues is really important. Biofeedback can also be helpful. It's essentially controlling your autonomic nervous system. So we know that deactivating the autonomic nervous system can actually improve seizure burden in some kids, and also can improve anxiety and depression symptoms as well, like working on deep breathing, guided imagery, all these things to turn on your parasympathetic nervous system and turn down your fight or flight. Psychiatry is always something to consider. We know that psychotropic medications are not necessarily contraindicated in epilepsy, but I always think that, we're a team here in our department or at CHOC, and it's important to collaborate with our providers. And I think similarly, if you're working with a psychiatrist, whether it be at CHOC or an outpatient setting somewhere else, that the treating neurologist, the neurologist working with the child on epilepsy, also is collaborating with the psychiatrist to ensure that there's no negative or contraindications with the medications. Then I also a plug for our epilepsy support network. They do a fantastic job here, and I think it's helpful to for parents to interact with other families who have either gone through similar experiences or who are currently going through experiences, or sharing ideas and thoughts and wisdom about how to navigate the community, how to navigate or find therapists, and also how to deal with the school districts. So at this point, we are a little over, I apologize, but questions, thoughts, hypotheses, discussion points? Let's see here if I can close this out. Oh, stop share. Just want to make sure. All righty. If there's nothing else, we'll go on to the next talk.